Okay, well, so my talk, first of all, welcome all of you. It's so great to see you all here. It's so great to see each year this conference continue to grow, and proud to be here. So my talk is vital perioperative protocols in lipedema reduction surgery. Uh-oh, where's the little clicker here? Green, right? Oh, there we go. Okay, so I still have nothing to disclose. And my experience, so I founded the Roxbury Institute many years ago. We have facilities in Los Angeles, Salt Lake City, Utah now, and we opened up the Diagnostic and Preventive Center with Karen Herbst in Tucson, Arizona this last year. I pioneered lipedema surgery in the US over 25 years ago in the mid-1990s. I've done between 8,000 and 9,000 surgeries. I do typically about 6 to 8 each week, but sometimes as much as 12 when I go to Utah. And I founded the Lipedema Society in 2015. Karen Herbst is the president of it, and Sherry Fitzpatrick, who's in the audience here somewhere, is the executive director. This is a book that I wrote. It came out last year, I believe. And it really is a good guide. And a lot of things we're going to talk about are in the book, and that's why I'm referencing it here. I talk about a lot of different concepts and my philosophy and principles. And so the book runs through all of that stuff, which I'm not going to do today. I've done that in the past, and a lot of my techniques surgically with liposuction for lipedema. I also have the ALT program, and it's a comprehensive program which is dedicated, and this is an important term that is going to be a theme of my little 10-minute talk, dedication. It's dedicated to lipedema and Dercum's patients. I have fellowship-trained dermatologic surgeons that do the lipedema surgery, Dr. Ari, Dr. Smart, plastic and reconstructive surgeons, and we have a whole team of anesthesiologists, CRNAs, clinical nurse practitioners, CLT therapists, nurses, coordinators. Again, it's about that dedication, that comprehensive approach to the care of lipedema patients. So lipedema and Dercum's patients have important and unique perioperative considerations, exclamation point. And this is a really important thing. This is, if you get one thing from this talk, both providers and patients, is lipedema is a complicated disease. There's so many things about it. And you continue to learn and continue to refine things. And I think it's really hard to dabble in lipedema surgery. You really have to have a dedicated team and the right type of protocols. And my protocols have evolved over many, many years and thousands of patients. And we began this. We now have regular scheduled team quality assurance meetings with the surgeons, the clinicians, anesthesiologists, the nurses, decongestive therapists, and we get together and we go through different protocols, and we're constantly looking to optimize and revise protocols. And some of these things we're going to talk about came from these meetings. We're going to run through a lot of different areas. You know, I sat down to do this talk, I was quickly humbled. I'm like, oh my goodness, this could really be a 1 or 2 hour talk. There's so many different things to cover. How do you run through this in 10 minutes? So we're going to go through a number of different areas. I will say this, that surgeons are unique. We have our unique way of going about doing things, which is sort of the beauty and artistry of medicine and surgery. And we definitely have all our unique perioperative protocols, you know, whether it's how long to wear a garment or when you can start walking, all that stuff. So some of you in the audience may disagree with things, but that's okay. You know, it stimulates thinking about all this important stuff. So we'll run through some of these areas, the things we talked about, intervals between surgeries, antibiotic prophylaxis, which is a pretty basic thing, DVT prophylaxis, important area in lipedema patients, hydration, another very important area. We spent a long time optimizing our hydration protocols, hemoglobin monitoring, decongestive therapy, reconstruction on patients, and aftercare on patients. So preoperative requirements, again, a lot of details here. We do, typically most people get medical clearance on patients. We do at least 2 weeks before. It's good for 90 days. High-risk patients, which we're going to talk about separately at the end, there's a special additional medical clearance from specialists in certain patients. A whole bunch of labs we get as our lab panel. Again, everybody has their own lab panels. Blood thinning medications are stopped again prior 2 weeks, like in all surgeries. GLP-1s, as we know, should be stopped at least 2 weeks prior to surgeries. We stop food 8 hours prior and clear liquids 2 hours prior. Now, again, I prefer to do this under twilight and avoid general anesthesia. There's other requirements for general anesthesia with things. We hydrate patients beginning before the surgery, 1 week before, and with electrolytes, and HypoCleanse the night before. And then, this is another important thing, pre-decongestive therapy, uncomplicated patients, 1, 2, and maybe early 3 patients who are not very fibrotic, they're going to continue their compression protocols, MLD therapy and garments. The complicated patients, you really want to identify them and triage them out and begin more of an aggressive pre-surgical decompression therapy with pump therapy, probably even bandaging, wrapping a lot of these patients. Grouping interval, again, my book goes through all this stuff, so a lot more detail about it. I do things either what I call 2, 2.5, or 3 surgery plans. People all say, what is half a surgery? Isn't that a full surgery? Well, in my world, it's a partial surgery. And the grouping of things typically is as the calves and ankles are done with the arms, that's a full surgery. Thighs or circumferentially is a full surgery. Hips, pelvic girdle, and possibly a torso is another full surgery. Those things are done a month or more apart in patients. Partial surgeries, if I'm doing the arms, along with the full surgery, I will do that a day or 2 apart for many reasons of clearance of lidocaine levels and decongestion. Let's see here. Antibiotic prophylaxis, there's not a lot to say. I mean, I'm sure we all prophylax our patients with antibiotics. It's a smart thing to do. You know, I have once in a while patients says, I don't want to do it, but it really should be done in patients. We use Duracef as our primary medication. Penallergic patients get doxycycline. Important area, DVT prophylaxis. So I strongly feel that it's important to prophylax patients undergoing lipedema surgery for DVTs. Patients have hypercoagulable states, factor V latent deficiencies. A lot of times they have decreased mobility. There's compression garments and bandaging and wrapping after surgery. Patients are prone to DVTs. You want to do everything to reduce the risk of that. So all my patients begin Lovenox, 30 to 40 units, depending on their weight, for 5 days, starting the day post-operatively. They must be on anticoagulation when they are flying home. That's, again, another thing I could be talking about. But when they're flying home, like most of my patients do, they are on anticoagulation. They will walk on the flight for a few minutes, every 90 minutes. I know it sounds funny, but that's part of my protocols in terms of moving things along. And patients that have a history of clotting disorders, you know, numerous DVTs, PEs, we will always coordinate the anticoagulation protocol with their hematologist. Hemoglobin monitoring, we check it preoperative, of course. It's normal to drop as much as 1, maybe even 2 points during a full surgery in patients, even despite the best techniques with things. We check finger sticks at 24 hours. If it's over 10, we're fine with things. If it's 9 to 10, at 48 hours, we check a CBC blood draw. If it's 8 to 9, we recheck that and monitor symptoms. If it's ever less than 8, which is very unusual, that patient will go to the AR for possible consideration of transfusion, which I think I've only had in 1 patient. Moving right along here, hydration, probably, you know, again, one of the most important areas. Patients with lipedema move fluid across membranes. They're prone to dehydration and POTS, which I think is actually a normal thing that goes on in lipedema patients, POTS, postural orthostatic tachycardia syndrome. We hydrate them prior to surgery, like I mentioned. During surgery itself, they get IV hydration. In the recovery, typically 2 to 3 liters. They orally hydrate afterwards, and then we check vitals and orthostatics for 1 to 2 days. And in certain patients, we will IV hydrate them for 1 to 2 days. Usually the thighs, I'll tell you, the thighs are an area that's commonly prone to dehydration, less so the calves and ankles and arms. Decongestive therapy, I talked about this. We'll run through this quickly. Uncomplicated patients, again, don't do any fancy pre-surgical therapy. The complicated fibrotic patients, we begin bandaging and wrapping and pump therapy on them. Afterwards, they do MLD therapy in our center with our decongestive therapist. Another thing that it's important, anybody doing lipedema surgery has got to have all this stuff lined up properly with it. They'll do it 3 consecutive days, and then afterwards 2 times a week or more for 4+ weeks by a qualified CLT therapist. So we vet out who that person is going to. I've learned my lesson. Patient goes back home to an unqualified person, it's a potential problem. Patients, we don't have them remove garments for 5 days. Patients, they remove garments, they're prone to again, orthostasis and stuff like that. Restart compression pumps in 3 to 4 weeks. Combination excision surgeries, brachioplasties, most of them are done concomitantly. Thigh-plasties, again, most concomitantly, sometimes staged. Abdominoplasties, we typically will do them as a staged procedure. Let me just run through this. Aftercare, 80% of my patients go home to a hotel with a responsible friend or family member, 15 to 20% with an LV and an RN. Very few of my patients go to an aftercare facility. I don't think it's really necessary except with certain types of patients. Finally, special considerations in high-risk patients. This is again where I will always coordinate care. I deal with patients with renal failure, seizure disorders, cancer patients, pulmonary patients, so I'll always involve that specialist. We'll actually usually talk on the phone to make sure that we're coordinating the care in the patient in the best way possible. Any special considerations that they have in the perioperative period, I think it's a very smart thing to do. And this is my work family. This is at our opening in Utah several months ago. And then this is my real family. This is us in the South Island of New Zealand around the holiday period. So thank you very much.